In the next 5 to 10 minutes, I will discuss with you the importance of tailored treatment of heart failure. This is my declaration of interest. Now, we know that historically the uptitration of heart failure medications has followed the time of discovery or demonstration of efficacy of the different drugs. So there's we should start with an ACE inhibitor, followed by beta blocker, an MRA, then switch the ACE inhibitor to an ARNI, and so on. But there is all the problem with this approach is that whenever either after discharge or whenever we see patient with heart failure, if he or she is not optimized on medical therapy, they're exposed at increased risk. And this is especially important in patients after an acute episode of decompensation, as we may see that the first 3 months are important after the hospitalization because they carry a very significant adverse prognosis. We also know that if heart failure therapies are not started in hospital or by the specialized centers, they are not started in outpatients. And you can see on the left how patients hospitalized receive uptitration of their medications or their initiation, whilst if they are outpatient, they are either continued or discontinued, or in some cases discontinued on therapies. Now, there is clear evidence that we need to use more than one drug, and if we use more drugs, it's as highlighted here in this meta-analysis by Michael Komajda, there's a significant prognostic benefit. So I believe we have to leave the approach that has been used by the old guidelines in 2016 of a stepwise approach to treatment, where you start with an ACE inhibitor and beta blocker, then add an MRA, and then switch on. And this is based mostly on the evidence that came from 2015 onwards, demonstrating efficacy of other new medications and the need to integrate them into medical therapy. This has been also highlighted by the guidelines of the Heart Failure Association and the European Society of Cardiology that recommend the ACE inhibitors, beta blockers, MRA, and dapagliflozin or empagliflozin as the core therapies, the 4 pillars that should be used in all patients. Of course, sacubitril valsartan can be used in patients who are still symptomatic despite a full dose of ACE inhibitors. So this is how the new guidelines look, and this is similar also to other guidelines, where basically we need to provide patients with a pillar of medications, then phenotype according to the left ventricular function, sinus rhythm, and if symptoms persist, then go into class 2 medications. A first attempt to phenotyping patients with heart failure and suggesting different possible therapies has been made with the guidelines of the European Society of Cardiology and the Heart Failure Association, where once patients have been started on the core medicines, then they can be phenotyped according to the sinus rhythm, the presence of atrial fibrillation, the presence of the etiology like ischemic etiology, aortic stenosis, non-ischemic etiology, and therefore add other interventions. Now we know that starting and initiating therapies is difficult, is time-consuming, and especially the uptitration may be difficult. We know that we may start with an ACE inhibitor and beta blocker together. This has been shown by the CBIS-3, where an ACE inhibitor plus a beta blocker had a significant prognostic benefit. We also know that we can start the SGLT2 inhibitors without problems because of the neutral effect on heart rate and blood pressure. So when we look at the problems that were faced with the implementation of medical therapies, we see that all the drugs that we use tend to have some side effects that may limit their utilization, and this is mostly related to the blood pressure, heart rate, and renal function that is common to the diuretics, the ACE inhibitors, beta blockers, and ARNI, and the MRAs. So if we look more specifically at beta blockers, we know that it is very difficult to fully uptitrate them. This is the CB3 study, CB-CELD study, that basically looked at elderly patients with heart failure, where only 25% of patients managed to get uptitrated to more than 50% of the dose of either bisoprolol or carvedilol. And in the vast majority of cases, the uptitration was not feasible because of hypotension or AV block or significant bradycardia. So there's a need for a more personalized approach on the treatment of heart failure. And because as we face often different phenotypes, patients with heart rate and low blood pressure, patients with low heart rate, low blood pressure, then patients with low heart rate but normal blood pressure. And therefore, with the Heart Failure Association has come up with a way of phenotyping patients and guiding our treatment strategies. So we felt that the limiting factors for implementations are mostly heart rate, blood pressure, CKD, and presence or not of atrial fibrillation. And according to that, we can build something like 58 different phenotypes where we can give a guidance on how to implement the core therapies, the 4 pillars of the guideline-directed medical therapy. So let's say, for example, we take these patients who's in sinus rhythm with a good blood pressure and heart rate. There will be no problem in implementing that, the medical therapy. But as soon as we go into a patient with a low heart rate or low blood pressure, things may change, and therefore we need to adjust the dosage and the drug that we wish to implement or to uptitrate according to the condition. So, in conclusion, the heart failure guidelines suggest a fast implementation of the 4 foundation therapies in patients with heart failure reduced ejection fraction. However, we know that the uptitration may take some time, and we may miss the vulnerable phase. Therefore, we need to initiate all drugs simultaneously, not just at discharge, but at any encounter with patients with heart failure, being that at discharge, being that in a heart failure clinic or in an outpatient visit. And then our uptitration should be implemented according to the patient phenotypes rather than by the target dose of medications are very rarely achieved in clinical practice. Thank you very much.